Well, a very good evening to all of you. On behalf of the Kolkata Association of Ophthalmology, myself, Dr. Surjit Chakraborty, welcome you all for this evening edition of the seminar on Neuro-Ophthalmology, which is meant for the general ophthalmologists. Hope you will all enjoy this program. Though the time is very difficult, wish all of you stay safe and stay well. At the outset, may I invite Dr. Chandrima Paul, the President of the Kolkata Association of Ophthalmologists, to deliver her welcome address. Over to Dr. Paul, please.
Thank you, Dr. Surajit. At the outset, I'd like to say it's my honor and pleasure to welcome each one of you this evening to the Neuro-Ophthalmology webinar, which is actually meant for the comprehensive ophthalmologist. I'd like to extend my heartfelt thanks and a very warm welcome to our guest speakers, Dr. Pramod Kumar Paul, Professor Neurology, NIMHANS, Bangalore, and Dr. Rohit Saxena, Professor Neuro-Ophthalmology, AIIMS, New Delhi. We also have with us this evening our esteemed panelists, Dr. Sujata Guha and Dr. Tutul Chakraborty. A very warm welcome to you. We have three young case presenters with us who are the future of our ophthalmology, Dr. Prachi Subedar Ghosh, Dr. Ruby Mishra, and Dr. Arindam Roy. Not to forget our moderator this evening. He's a very accomplished and oculoplastic surgeon who is a surgeon par excellence and a moderator to reckon with. That's none other than Dr. Rajesh Majumdar Chaudhary. So a very warm welcome to each one of you once again, and to all those who are watching this webinar. Thank you very much, and over to you, Surajit.
Thank you. And next, the program will begin with Dr. Rajesh Majumdar Chaudhary. He will take over from here and carry the program as it goes. So, Dr. Rajesh, please.
Thank you, Surajit. Thank you, Chandrima. You know, for a student of science, I feel that the theories of quantum mechanics or principles of string theory would appear to be something very daunting to grasp. And I think for us, ophthalmologists who do not practice neuro-ophthalmology, neuro-ophthalmology probably belongs to that rarefied group of academia. And, you know, I personally feel that a successful neuro-ophthalmologist, of which we have so many of us here today, they need a deep clinical analytical thought process and really, you know, exclusive clinical acumen to be a successful neuro-ophthalmologist. And I'm really grateful to our team led by Dr. Chandrima Paul, Dr. Surajit Chakraborty, and last but not the least, Dr. Chandana Chakraborty, for arranging this academic feast for us today. We have two flagship speakers who are of international repute, and they're envy of any webinar, I would say. And we have an expert panel of consisting of Dr. Sujata Guha and Dr. Tutul Chakraborty, who wear many hats. You know, they're clinicians and teachers par excellence, and their reputation and their identities have grown far beyond from where they started initially. So they are also international figures to reckon with. We have three young Turks who will be regaling us with their exploits with various neuro-ophthalmic cases. And they will be proving, I'm sure, that they're ready to share the mantle of this very rarefied discipline which focuses all of us who are not actually trained for neuro-ophthalmology. Without much ado, I think I'm going to introduce you to our first speaker, who is Dr. Pramod Paul. I'm going to share my screen now. We are very grateful for Dr. Paul to have agreed to come to our meeting today. He is from Kolkata. He did his MBBS from Calcutta Medical College. Then he has gone from strength to strength from PGI Chandigarh and then NIMHANS Bangalore, where he is at present professor of neurology, of movement disorder specialist. He has got professional interests in various topics, including movement disorders, spinocerebellar ataxias, human motor physiology, and functional neuroimaging. His publications are, again, envy of any academician, and he has still holding positions all over the country in various neurological societies. If we have to discuss all of these, this is going to take another webinar. So I'm going to skip this, Dr. Pal, and I'm going to hand over the floor to you. Thank you so much for agreeing to speak to us today.
Good evening. Thank you, Dr. Rajesh and Dr. Chandana, Dr. Chandrima, and all other esteemed faculty and panelists. And I'm really grateful that I got a call from Chandana, who's my classmate. I've never seen her from 1986 onwards, and good to see you at least in the virtual platform. So I'll be sharing my screen first, and so let me see here. Yeah. Can you see the presentation?
Yes.
Hello? Is the PPT visible?
Yes, yes.
So what I'm going to do in the next 20 minutes are just give some glimpses of neurological disorders which can be diagnosed through the eyes. Okay. So, and I am fortunate to work with a neuro-ophthalmologist, so I have never actually gone to the depths of the neuro-ophthalmology. But what I'll go through in the next 20 minutes is just to show you that what specifically neurological disorder and specifically movement disorders, how it can affect the eyes. And sometimes if you see some cases, some video cases of these patients, there will be no problem in diagnosing these rare cases. Most of them will be rare cases. So this is my objectives, which just to discuss some of the common and rare disorders where examination of the eyes provide vital clues to the neurologists. Now, let us first start with the general appearance of a patient. And most important for a neurologist's point of view is whether the patient's eyelids are drooping or not. So that is the ptosis. So most common disorder which we come across the ptosis is, here is the patient of myasthenia gravis, which is an autoimmune disorder because of the antibodies against the acetylcholine receptors. You can see here before the neostigmine, he has ptosis, which is asymmetrical, and some ophthalmoplegia, which promptly improves after giving neostigmine. And that is a diagnostic test, and you need not do any other. So this we did not refer to an ophthalmologist also for that, but a ptosis. So that is one of the most important. But ptosis may not be restricted only to myasthenia gravis or muscle disorders. You can have, there are some of the important causes, and you can see here, this is a child who has mitochondrial disorder. You can see the MRI which shows abnormality, and this is a rare disorder where it is known as a Kern-Sayre syndrome, a mitochondrial disorder. Here the patient also has a ptosis. And these patients actually, mitochondrial disorders can have a lot of abnormalities in the fundus also. They can have retinitis pigmentosa, optic atrophy, and many other things. And this patient actually had ataxia, and biopsy is actually diagnostic. You can see ragged red fibers, etc. So the ptosis itself can point towards different diagnostic probabilities: Horner syndrome, mitochondrial disorders, multiple sclerosis, stroke, etc. Then let us come to the another general appearance. So if you see this patient, I'm just going to what is the conjunctiva, what it looks like. It is a telangiectasia. And this telangiectasia is very important for us. But you can see that this patient actually has other abnormal ocular movements, sometimes ocular flutter. There are a lot of abnormalities can occur in this patient in a disorder known as ataxia telangiectasia. They can have telangiectasia not only in the conjunctiva, but it can have in the soft palate, behind the ears, in other areas of the skin. And why they come to the neurologist? They come to the neurologist because not for the telangiectasia, they come because for the ataxia. So this is autosomal recessive disorder. They have ataxia of the limbs and the hands, the ataxia walking. They die early because of multiple infections, because it is, is a DNA repair defect. And you can see this patient also has a vitiligo. So, but apart from this telangiectasis in the eyes, there are a lot of other findings in the eyes, like they can have slow saccades, oculomotor apraxia, and oculomotor apraxia and slow saccades can, if you call the patient, suddenly there will be head thrust. So this is known as a head thrust, which they try to do a oculocephalic maneuver to overcome the apraxia or the slow saccades. So it is very important to pick up this telangiectasia, which may not be evident like in this girl. So then other important thing is cornea. So this is one of the most important thing which we look for in any young patient who comes with a movement disorder. So these are the two patients. Suppose these two patients have come with movement disorders. One with a very, very severe dystonia. It is autosomal recessive disorder, and another with a very, very severe Holmes tremor. This is incapacitating. You find, if we come to a movement disorder specialist or any neurologist, just look at the eye. 99% of the patients you will find a corneal ring, and it is the facial ring. You sometimes need not do any slit lamp examination. It is autosomal recessive disorder. It has lot of neuropsychiatric manifestations. You can have hepatic involvement only. You can hematological. So how they come to you? Actually, they come to us. They do not come to you, an ophthalmologist. But because it will never come to ophthalmologist. But we need to confirm the diagnosis. In some of the cases where we cannot pick up by clinical examination, KF ring, we need to do a slit lamp examination. In our setup also we have a slit lamp examination facility and etc. So this is, and it is a treatable disease. Like this patient, we all treat with penicillamine, and this patient can be treated with deep brain stimulation or surgical treatment. Then another thing which the patient sometimes general appearance, what is this patient has? The patient has a light ophthalmos, but you can see here the pulsating ophthalmos, exophthalmos. And this pulsating exophthalmos is a diagnostic of a carotid cavernous fistula, which is. So this, anyhow, we need to see the fundus, we need to see other edema, papilloedema, etc. But this type of pulsating ophthalmos, exophthalmos is a diagnostic of carotid cavernous fistula, sometimes other vascular abnormalities, sometimes neurofibromatosis, etc. Now let us come to the facial expression. Facial expression can tell a lot of things about neurological disorders, and sometimes you can see there is lack of blinking. So this lack of blinking, loss of facial expression is a characteristic feature of Parkinson's disease. Okay. But not all lack of blinking is Parkinson's disease. You can have what is known as a Parkinson plus disorders, and this patient, you can see here, there is a lack of blinking, there is a lack of facial expression, but in addition he has a staring look, a expression, always there's an expression, full of expression in the face, astonished look. And this is a classical diagnostic feature of a patient with progressive supranuclear palsy, where there is an eye movement abnormality. Initially supranuclear, later in nuclear or nuclear involvement. So here we are trying to do a oculocephalic maneuver to show there is a supranuclear involvement of this. And this patient has a severe, Parkinsonism, difficulty in walking, etc. So why we send to the ophthalmologist? Because they can, in the very early stages, they can go to and come to you to say that the patient is having a staring look, but actually this is a dystonia, why he is having a staring look. Now let us come to the next picture, where a patient can have the overactivity of the ocular orbicularis oculi, because see, this is a patient who has again a focal dystonia, a blepharospasm, which they are not able to resist, and they are not able to open the eyes. They are doing a gesture antagonistic or touching the face, and it promptly opens. So these people can come to you in the early stages, and the main treatment is Botox, botulinum toxin. It can lead to a functional blindness, and if you give treatment, actually the patient totally improves. Even in patients who have cataract surgery, etc., patients are referred to us to just treat first the blepharospasm, because it can distort. You can change the you can cause astigmatism, it can distort the cornea or eyeballs, etc. So it is very important to recognize. There is another group of disorders. It is not a blepharospasm, it is a hemifacial spasm, usually because of an aberrant blood vessel pressing the facial nerve. And here also you can see here only one side is involved, but the treatment is botulinum toxin and significant improvement after the toxin. So it is needed to recognize these problems, and promptly you can send to a neurologist. And this is a rare disorder where there is a Whipple's disease, where there is it is a bacterial disorder, but you can see here what is known as Oculomasticatory Myorigmia. These are also treatable disorders. With antibiotics, you have to treat for a long time. Again, this is a recognition of these ocular signs. So not only difficulty in opening or closing the eyes because of blepharospasm, you can have what is known as an apraxia. You call the patient, you tell the patient to close the eyes. He is not able to close, though there is no weakness. You tell the patient to open the eyes. They cannot do it promptly. These are very rare disorders where you can see this lady has an eyelid opening apraxia. You just see soon that after he closes the eyes, it cannot voluntarily open. She's now the eyes is closed. She's struggling to open it. Is not able to open. Then she uses a maneuver. These are all rare neurological disorders, but they can come to you. And this is a patient which we had reported. Here is an eyelid closure apraxia. After closing, patient needs, this is a patient of encephalitis. So patient is apraxia of closing the eyes. So I'm telling the patient to close the eyes. Then after struggling, the patient closes the eyes. So these are all higher cortical function disorder, and we need to recognize this. Now let us come to another group of disorders which can sometimes come to you. These are all, I'll just quickly go through. This is a tic disorder with constantly blinking of the eyebrows, and this is a excessive blinking which could be a forerunner of a patient with blepharospasm. And this is another, a young boy had a functional disorder. Sometimes they can have excessive blinking, sometimes they have one eye closing. So these need to be seen by child psychiatrists, and actually this after counseling you can see the significant improvement. We give suggestions after counseling, these patients improve. So overactivity, excessive blinking, lack of blinking, inability to open the eyes, these are all neurological problem, but they may sometimes in the early stages come to you. Now quickly I'll go through some of the eye movement abnormalities which I have already shown you, the supranuclear progressive in this progressive supranuclear palsy. But apart from that, we can have a lot of neurological disorders where there can be saccadic slowing. So we have eye movements pursuit. Saccade is the fast component, fast movement. So there could be reduction in the saccades, or there could be increased velocity of the saccades, so causing slow saccades, that is hypometric saccades or hypermetric saccades. Let us go into some of the examples. So this I have already shown, progressive supranuclear palsy. This is another patient of chronic progressive external ophthalmoplegia where the eyes doesn't move because there is a lower motor neuron type of palsy because of the muscle disorder. And you see by modified gomonitrin technique, the biopsy shows a mitochondrial disorder. So these are also important to recognize. This is not a myasthenia, this is not a PSP, but it is a muscle disorder because of the mitochondrial dysfunction. Now this is a girl who came to us with eye movement abnormality. See, you see when the patient is called, the patient thrusts the head. This is called a head thrust. There is significant eye movement abnormality, but this patient also has ocular apraxia and the patient has a severe ataxia. And if you do a bone marrow, biopsy, you will find C blue histiocytes, Umi cells in the bone marrow, thereby suggesting this patient has a pneumonic disease, which is a mutated genetic disorder. And these are actually very childhood onset ataxic disorders. Then these are the two prototype of patients with spinocerebellar ataxia, SCA2. This is a patient who has SCA2. SCA2 is one of the chronic ataxic disorder who has autosomal dominant inheritance, runs in the families, and they have eye movement abnormalities, slow saccades, ataxia, and peripheral neuropathy. So what is happening here? I'm telling the patient to look towards the left, towards the right, and the patient is not able to do. There is eye movement slowing, and the patient is using a oculocephalic maneuver called head thrust. This is a patient with one of the scars, either one or two, but this is important to recognize that when we are telling the patient to look to the left and then to the center it overshoots and then comes back. So this is known as a hypermetric saccades, and these are also have a diagnostic level in different SCA disorders. So sometimes you may, when you are doing ophthalmoscopy, when you are seeing a patient, sometimes the patient may have this type of movements. Then another movement which is often, it is a very rare, it is called downbeat nystagmus. See, this patient is a spinocerebellar ataxia type 6. You see here, this patient has, these are all genetically proved my cases. You see this, when the patient is looking, there is a nystagmus towards the lateral side, but after some time, you will see there is a downbeat component is there. and then we do this perverted head shaking nystagmus and see. So you can see now the downbeat component is oblique. So this is a classical case of a spinocerebellar ataxia type 6. Sometimes this downbeat nystagmus also can give clue to different type of disorders other than spinocerebellar ataxias. And this is a patient who had a breast CA. I think this patient had a, let us see, this carcinoma breast 5 years back, and later on developed this type of downbeat nystagmus. So these are diagnostic of a paraneoplastic disorder, and this patient actually had a anti-GAD65 antibody positive. So again, downbeat nystagmus has its own value in different diagnoses. Then we see a couple of patients with Joubert syndrome. These patients actually can come to the ophthalmologist first. So you can see a Joubert syndrome. First, I'll tell you what it is. It is a ciliopathy, and ocular abnormalities in Joubert syndrome can be congenital ocular apraxia, ocular tilt, alternate skewed patients, strabismus, etc. And actually, MRI shows a molar tooth sign because of the lack of the superior cerebral peduncle. Now, how do they present? They can present with, these are all my patients, all proven, see, you can see this type of a sudden deviation of the eyes, or this is the patient had a alternate hypertrophy stool. These are all published cases of abnormal eye signs in Joubert syndrome. And in addition, they can have a respiratory signs, a thrusting of the tongue, etc. This patient came with myoclonus as well as ataxia. So just I want to highlight the eye movement abnormalities which these patients can have starting from early infancy to childhood. Now these are the patients. I'll just skip this the time shortage of time. So sometimes we can see patients with ocular flutter. This is not my patient. It is from the textbook, but this is the patient who had what is known as the ophthalmologist myoclonus ataxia syndrome. Sometimes this patient, so ophthalmologist means this is little treated. These patients have a viral infection or a RNA malignancy, and they develop this ophthalmologist. This is suddenly, if you put an eyeball in a bowl of oil, it will be floating like that, chaotic movements. And apart from ophthalmologist, these patients actually have ataxia and myoclonus. So if a child comes with this, we have to think about neuroblastoma. If an adolescent comes, we think about post-viral, or sometimes the autoimmune antibodies can be there. LMDI positivity should be ruled out. So there are patients with multiple sclerosis, the internuclear abducting eye has nystagmus, adducting eye complete, and this is a patient with oculogyric crisis. Sometimes they can come with, after getting neuroleptic drugs, they can have certain deviation of the eyes upwards because of the oculogyric crisis. So then we just show one or two. This is a young girl who had a very rare type of leukodystrophy and had a pendular nystagmus. It is a disorder called Pelizaeus-Merzbacher syndrome. There are I think our audience, our panelists has a pediatric neuro-ophthalmologist. They must have seen these cases, but these cases rarely come to us also. So this is a congenital pendular nystagmus. This is a patient with periodic alternate nystagmus, which can have a diagnostic value. The nystagmus direction is towards one side. After some time, it changes the direction, and sometimes patients with vertigo can have a rotatory nystagmus. So I think I have another 5 minutes. So let us do the two. Sometimes we refer to the ophthalmologist because of cataract. Now, cataract in our neurology has a lot of different meaning apart from. So this patient, Wilson's disease, which is shown, can have cataract, sunflower cataract. These are patients of Marinescu-Jogren syndrome. Again, they had actually early cataract without any obvious cause. And this is a patient of cerebrotendinous xanthomatosis. Xanthoma you can see here, on the tendons, and this patient also had. So these patients have bilateral early onset cataract, which they get operated. Later they develop xanthomas and ataxias, etc. So this is a diagnostic. This xanthoma is actually diagnostic of these disorders. And this is a patient which we reported earlier, but this patient may not have, but patients of pseudo hyperparathyroidism again can present with cataract. So I'll not go into the details of these pupils which are very important for us: Argyll-Robertson pupil, Edis pupil, Horner syndrome, and pupillary defect in multiple sclerosis. Some of the fundus pictures are really important for us, like cherry red spot or macular degeneration, gyrate atrophy. We had seen one patient with hyperornithinemia, retinitis pigmentosa, and PCAN mutations. So I'll just show you one of my patients when we get retinitis pigmentosa or optic atrophy also, these are the patients who come with childhood onset disorder and they have what is known as Pantothenous kinase deficiency. These are the progressive, neurodegeneration with brain and accumulation. They have a shortened lifespan, severe nuchal dystonia, later severe eye movement abnormalities they can have, and they have the eye of a tiger sign, mineralization of the basal ganglia. So these are characteristics. These are autosomal recessive disorders. Now, this is another area where we always send to the ophthalmologist, and these are the retinal changes in neuroinfections. A recently published paper, not our, I think this is from Rishikesh, AIMS Rishikesh. You can see here, we always look for this type of cysticercosis seen under the retina, and this is, I think, one of our patient, not the same patient here, where you have cysticercosis in the orbital space. So these are very important to pick up so that treatment changes. So this is another child with retinitis, cherry red spot, and this patient actually had absence, Nycol, because the autism subtle, and this is the patient of GM2 diabetes or Tay-Sachs disease. So there are many other causes of cherry red spots, and the final sometimes you see patients, you give a lot of photic stimulation. Some of the patients of photic stimulation, if you give eyes, photic stimulation to the eyes, can result in nystagmus, jerks, or sometimes epilepsy. So this is a patient of CJD, later on turned to be CJD. But you can see here, as soon as we give photic stimulation, they have stimulus sensitive, photic stimulus sensitive myoclonic jerks. And this is another patient. This is courtesy Sajib Sinha. Here you can see stimulation. They develop a ocular. This is eyelid myoclonus they develop. Some of the patients who have photosensitive epilepsy, a child can go and put the hand in front of the sun, and they get a pleasure out of getting this photic stimulation and thereby producing a seizure. So this is another patient. I think I have just ended the talk. So again, while the photic stimulation is occurring, you can see here some myoclonic jerks and EEG abnormality they can get. Thereby, what I am trying to say is that when you give a lot of photic stimulation, sometimes seizures can be precipitated in patients who has this type of abnormality. And another thing is the loss of vision is always, sudden occipital blindness, these functional blindness, sometimes, they may go to you, but probably the diagnosis we have to establish because of the other things we need to know for functional blindness as well as occipital blindness, where there is occipital infarct and nothing you may be able to see in the eyes abnormality. Visual potential, evoked potential, obviously we have our own role in diagnosing different type of disorders. So I think I have taken enough time, and this is our team of Niemann Parkinson's disease and movement disorder subspecialty. Most of the videos which I showed are 9 patients of movement disorders. Some of the patients I borrowed from some of the other colleagues, and this is our website, and thank you very much for your attention.
Thank you so much, Dr. Pal. Thank you for your encyclopedic presentation. And for me, I think the point I really like about this whole presentation, and hopefully the juniors here also will take note, that the importance of documentation, photographic documentation. They're so crucial for any kind of management, be it neurology, be it neuro-ophthalmology, be it in any other discipline of ophthalmology. I know Dr. Pal is hard pressed for time. So
no, it's okay. It is nothing, but I think Dr. Rohit is hard pressed for time, I think. But what I want to emphasize is that these are, all the collections, teachings over the last 20 years, and documentation is, as you emphasize, video documentation with appropriate consent is very important for teaching purposes. When you develop a department, when you develop your own students and teach, these are rare cases over years you come across. This documentation is very important. Absolutely. And I was actually fortunate to have with me my neuro-ophthalmologist who practices outside, but she always comes for the last 20 years when I was a student also, as well as Dr. Bakula Kashyap, who really helps me in getting all the fundoscopy and all those things, and we work in tandem. So ophthalmologists, actually we work in tandem, neuro-ophthalmology and neurologists, all of us.
I would like to have a little input from our experts about Dr. Pal's fantastic presentation. I'll ask Dr. Sujata to go first, and then Dr. Tupul Chakraborty, please.
Dr. Pal, it's such a wonderful presentation. We always see from the other side of the coin, that is, we see the eye, and it is it's such an enlightening presentation to see the movement which accompanies the disorders of the eye. Absolutely mind-boggling set of collection. So thank you so much. And another thing I would like to say, when we practice as neuro-ophthalmologists, we always have a team. We always have a team up with neurologists, neurosurgeons, and geneticists. So as Dr. Pal mentioned, it is imperative to have a team when you practice neuro-ophthalmology. You cannot be a standalone neuro-ophthalmologist. That is a very important thing. And as ophthalmologists, we exactly know when to refer to neurologists, because it is important we work together. So it's a team.
You. Dr. Chakraborty, please.
Yeah, I have a question. Can you hear me?
Yeah, sure.
Yeah. Dr. Paul, I mean, when we get the patient of myasthenia, can we do ice-pack test instead of neurostigmine? Because in chamber practice or outdoor practice, sometimes it's very difficult to do ice-pack test. Is almost there is no risk at all, and sensitivity and specificity, both are okay. I don't know. Dr. Rohit is there and you are here, so your input is very important here.
See, we have actually all patients which come to us, we always go for the clinical as well as the neostigmine and the decremental response, that is the electrophysiology. In some cases where it is not positive, then we give eyes and then do the decremental response, we do the EMG, etc. So I generally, because I have moved out from the neuromuscular disorders, but I have not done any time, except for 1 or 2 cases. But do we need to do ice pack? How many patients you have done ice pack actually? And what you see, do you have a practical experience with that?
I have this practical experience. That's why I'm in, because in unless it's a hospital, sometimes you have your patient in your own chamber because you are always.
I feel that once you demonstrate a fatigability, the fatigability is a clinical observation. You just tell the patient to look up like this, and after 15-30 seconds, if there's starting drooping of eyelids, almost it is a definitely do. But yeah, you can do the test. But I have personally not done, except for the initial few years, long time back when we used to do some of these things. Otherwise, we have gone to the clinical test and decremental response.
And one more, I have seen Professor Peter Savino also in. He also is very comfortable with ice pack test. I don't know, Doctor.
Hello, Bolun. So, we rather frequently do the ice pack test. As Dr. Tuttle is saying that, getting a neostigmine test or you sending them for decremental velocity, all that takes time. One, for a teaching point of view and an early diagnosis point of view, because more often than not, we would be treating these patients in conjunction with neurologist. So it's very useful in the beginning to actually think whether this ptosis, which is the primary presenting problem, is something that we apply our mind locally and look around as an ophthalmic cause, or seriously start considering it as a neurological manifestation. So a fairly good sensitivity and specificity has been reported for ptosis. Unfortunately, that is not true for strabismus. So if a patient has movement disorders of the eyes, it is not supposed to be as effective because the cooling does not reach to the actual muscular part of the extraocular muscles. But the ptosis has been seen to have a significant and fairly remarkable improvement. And a couple of studies, in fact, done sometime a couple of years ago also have shown a fairly good clinical correlation with the neostigmine. But as you said, finally, of course, the confirmed diagnosis is always with neostigmine and by doing EMG and, of course, antibody testing and CT scan just to rule out. If you are actually thinking in those lines. So
because we get the cases almost, we do not do actually. Yeah.
I understand. I mean, it's obvious. I mean,
yeah.
That's the different approach. Like I said, from a neurologist perspective, you usually
Definitely.
have fairly good, clear features presenting. When they come to us, they come to us fairly early with, you know, recent onset, especially unilateral ptosis.
Yes.
So, you know, it becomes very imperative that I rule out a local cause. And if I see an improvement on ice pack, I'm fairly certain that I should go explore towards myasthenia. And if it comes negative, then it still does not rule out the presence of myasthenia, but I'm still a little more sensitive towards, you know, trying to rule out local causes, trying to worry about orbital reasons, which may be responsible for the recent onset or acquired ptosis. So it's a good, you know, helpful investigation or test, very quick, rapid, you know, OPD basis, you could actually differentiate. So that's what our approach introduces ice pack fairly importantly. So Rajesh would also have a lot of experience with acquired ptosis coming to him.
Well, you know, what I can say that, you know, as Dr. Pal said about the fatigability test, in my experience, I've seen that even in involutional ptosis, you can sometimes have a false positive fatigability test, actually. So, you know, some people with age-acquired ptosis can show worsening with, you know, fatigability test.
Right.
With that, I mean, can you just move on to Dr. Saxena? I know he's, again, like Dr. Pal, very, very busy. And thank you, Dr. Pal. It was a pleasure to have you here. Thank you so much.
Thank you. Bye.
Dr. Saxena does not need an introduction, but still it's only polite that, you know, I do that for him. So we have already heard him speaking and we all know who he is. He's a true blue alumnus of AIMS New Delhi. He has been publishing hundreds of papers and he has been guiding dozens of PhD students. He has edited books. He has authored chapters. He has been speaking about his passion, neuro-ophthalmology and strabismology, at various conferences all over the world. He has achieved so much fame that I suppose his mantelpiece is heaving now with awards. And he has been doing other things as well. In his other avatars, he has been members of various projects of Department of Science and Technology, and he has been past secretary of Delhi Ophthalmic Society, and he has edited the Delhi Journal of Ophthalmology as well. So without much ado, I'll leave the floor to Dr. Saxena to again enlighten us with his wisdom. Thank you.
Thank you, Dr. Rajesh. Thank you very much. Are my slides visible?
Yes.
Great. So again, it's an absolute pleasure to be here. My thanks to Dr. Chandrama and Dr. Surajit for organizing this, and Dr. Chandna for giving me an opportunity to be here. I'll try to you know, have a little less complicated neuro-ophthalmology, because I know it tends to put off everybody, and suddenly you will find very, very few people who are listening to us. So, and of course, these are COVID times, and we are all recovering from a major pandemic, and we hope that things get better. So I'm glad I have this chance of discussing neuro-ophthalmic manifestations of COVID disease, and we kind of ad nauseum know about this coronavirus for almost 1.5 years, and I think all of us are now semi-experts in identifying, and if we meet him on the street, I'm sure all of us will recognize him very easily now. He's going to have a little thin slit eyes because of his origins, but we know that bulk of the symptoms of the patients present to us are respiratory, because that's usually the site of entry, and fever, cough, fatigue, shortness of breath was something, you know, over the past 1.5 years, we've kind of been very touchy, very sensitive about. And recently, especially in the second wave, we have realized that a lot of systemic issues are picking up. In fact, this wave had a lot of GI symptoms, particularly diarrhea. Many patients presenting to AIMS didn't have any, you know, preceding respiratory or associated respiratory issues. We know that they have hematological problems and coagulation and all. We know they are presenting with renal issues, and a lot of them initially were having, especially early second wave, had a lot of neurological problems that have been reported. And of course, associated with that, we realized initially we were kind of very comfortable thinking that, as an ophthalmology department, except the fact that an ophthalmologist unfortunately was the first one to identify it and paid with his life. But as such, we are, other than conjunctivitis, which has been reported, is not such a big deal for us. But we realize that there are a lot of ophthalmic manifestations from anterior segment, posterior segment, orbital, and neuro-ophthalmological. So just to quickly get these important ophthalmic manifestations, which are very important for us to know. Generalized pain, Bacteroidenitis, dry eye is a very highly prevalent symptom among patients of who even had mild COVID, so it's something we need to be aware of. Many have complained of congestion, watering, irritation, foreign body sensation. There have been studies that have picked up the virus from the tears, and although we are still not sure whether it is contagious or the tears are contagious, but we are supposed to take fair amount of care about it. They presented with conjunctival, subconjunctival hemorrhages, conjunctivitis, episcleritis, keratoconjunctivitis. We've had a lot of patients of vitritis and vasculitis present. That has been not so rare now. And of course, orbital cellulitis, orbital inflammation, and of course the much hyped and much talked about mucormycosis, which probably we should avoid because of massive discussions that we have done. So what are the neuro-ophthalmic manifestations that we have come across? And as we are going more and more into the completing greater time from COVID, and we are understanding and entering into the post-COVID problems, and now it's a defined problem of post-COVID problems of post-COVID disease, we're realizing that a lot of neuro-ophthalmic manifestations are occurring. And we'll just go into what could possibly be the reasons, but we know that people have had case reports, and many reports have talked about tonic pupils. People have presented with double vision, basically due to motility defects, part of cranial nerve palsies. Sixth nerve has been particularly frequently reported. Nystagmus, a lot of CNS symptoms associated with nystagmus, a Miller-Fisher triad, myasthenia gravis. We just talked about myasthenia, and we've seen a fair amount of cases of myasthenia now. These were all the efferent issues. The afferent issues would be vision loss, which could be related to optic neuritis, papilloedema, papillophlebitis. NAIN has been reported possibly because of the prone positioning that has been done, and that could lead to an orbital compartment syndrome with increased pressure and causing a compression of the blood flow to the eye, and a thromboembolic phenomena, so which we know occurs in these patients in the post-COVID period or even in the late COVID period. We've seen visual defects come, which would be because of CVAs or strokes, and disc edema and papilloedema, which we saw a lot more in the first wave, and now I guess as the second wave recedes, we would see these patients coming to us. Some of the miscellaneous ones have been headache, so a lot of patients come with headache. Of course, a lot of children are coming with headache, probably because of a lot of near use, and a lot of adults also because of much of the activity is now online. Myalgias, generalized body ache, weakness, strokes we talked about, cerebrovascular accidents, large vessel ischemic strokes have been reported, and a posterior reversible encephalopathy syndrome. So these are among the other features which some of them are in the neurology realm but may come to us also to start off with. What are the possible mechanisms? So again, as we are understanding this disease, we are probably trying to get to know more and more ways in which this virus interacts with the body. Rarely, some cases have discussed a primary neurotropism of the virus, that it directly enters to the nerve and causes a direct effect of the nerve. And this we've seen in one or two cases of third nerve that have been reported, which have shown significant enhancement of the nerve with a third nerve palsy, showing early presentation and of course enhancement. So possibly there is primary neurotropism that has been rarely reported. Most commonly, it is an immune response, which is probably part of a generalized upregulation of the immunological response. And many of the antibodies that are cross-reactive with antigens on the SARS virus. So the antibodies responding to SARS virus may actually cross-react with parts of the body. And of course, part of the generalized cytokine storm. that can introduce a lot of these antibodies in the body, and of course they could attack anywhere. There is major proven complications due to hypercoagulable state, vascular occlusions, and ischemia, and this has been quite definitely seen, as we know that there is a hypercoagulable state. We'll touch upon vaccine-related, which is more scary or more worrisome for the general public, but it's still not conclusively proved. And of course, incidental, I'll try and tell you what we mean by that. So these are all the ways patients have presented: headaches, vision loss, disc edema, so which could be due to optic neuritis or papilloedema, diplopia, which could be due to cranial nerve palsies or neurological syndromes, eye movement disorders, which would be nystagmus, myasthenia gravis or part of neurological syndromes, field effects, which would be part of CVA and stroke, and other miscellaneous ones. So I'll just run through we just see a couple of cases as we go. And optic neuritis has been reported in the active as well as in the recovery phase, but usually we've seen about a month after they have developed COVID. So in the recovery phase, they come to us. So it possibly could be an inflammatory cytokine storm that is causing the neuritis in these patients. Reports have been that they have turned positive. So NMO positivity, MOG positivity, these are all antibodies observed in the blood, definite syndromes, but patients presenting with optic neuritis post-COVID have been seen to have NMO and MOG positivity, and some of them are actually seronegative. So just have optic neuritis without any positivity of any syndrome. And we've seen that some patients present with a generalized demyelinating disease like multiple sclerosis. This was a patient who came to us with optic neuritis about 2 weeks after the COVID, had bilateral involvement, disc edema, and recovered with IV steroids. So we're not sure that these are actually directly related. That's why the word incidental. It could be that they are part of the COVID problems, but it could be that COVID is affecting lakhs of patients all over the country. So some may just incidentally have, an episode of optic neuritis and would have probably normally had it also. But because of its timing, temporal relationship, we are associating with COVID. This is a published case in the JNO by a US group, which again talked about very clear. They found a fairly significant association, very temporal and close association, and they labeled it as post-COVID optic neuritis. Papilloedema is again something we saw much earlier, and even now we expect it to be increasing as we also increase our OPD. It is probably due to increased weight gain due to reduced activity, and all of us like to snack watching television. So a lockdown weight gain has been seen. The other possible reason could be the hypercoagulable state causing a venous sinus thrombosis and then presenting to us. So hypercoagulable and pro-inflammatory states are predisposing to papilloedema. So patients have presented with papilloedema sometime 2 to 3 weeks after their COVID, but even later, much later on, and probably unrelated to COVID, like I said, it could be just because of a recent onset weight gain. Orbital inflammations have been seen. These are again 2 case reports I have picked up from JNO. There is a site in JNO where they're reporting all the possible case reports of association with COVID so that we are over time able to understand the disease. And you can see a diffuse swelling in the orbits. Here you can see a diffuse orbital inflammation post-COVID patient presenting with vision loss and motility defects. This was a patient with 6th nerve paresis. Again, that's one of the most common presentations of motility defects that we've seen post-COVID. One of the patients had optic neuritis with limitation of movement, and you can see there is a perineural sheath involvement with adjacent involvement. This is again from the JNO, where they have shown that both optic nerve sheaths were inflamed with adjacent edema causing a 6th nerve palsy. And of course, motility defects with mucormycosis. Initially, we were the ones, ophthalmologists were the ones who were actually picking up mucormycosis because they were presenting late, where the mucor had actually infiltrated into the orbits and presenting with vision loss and motility defects. And we did pick up fair amount of cases. In fact, it was ophthalmologists who were actually discussing in the forums that mucor is a possibility, and it's more common now that we are seeing. And now, of course, with early sensitivity, it's the ENT people, thankfully, who get to see the patient first before it actually spreads into the orbit or into the cavernous sinus. Ocular myasthenia gravis, again, it could be generalized antibody reaction, or it could be antibodies against the SARS, which may cross-react with acetylcholine receptors. And again, there is an upward tick of patients presenting with ocular myasthenia gravis. Nystagmus, we've seen a lot of neurological problems that may present with nystagmus, and many patients are coming. Again, we get referred to neurology and not really directly. CVA, again, increased patients presenting with CVA. In fact, neurology ward is full of strokes at the moment, an unusual time of the year to actually see strokes. They usually see in the winter months. So there is probably an association with COVID, either directly because of the coagulation that we see in these patients, or again, possibly because of major changes that are happening systemically. Tonic pupils have been reported, 1 or 2 are associated with conjunctivitis, so we are not sure whether it entered through the eye or it's a systemic involvement. And of course, pupillary involvement of the third nerve is seen, and of course, along with encephalitis or other things. Just a word about vaccination. Neurological, including neuro-ophthalmological side effects post-vaccination have been reported. Usually, patients who report within a day or two probably are because of the adjuvants of the vaccination and not, or the vaccine, and not the vaccine per se or the virus particle per se, because these adjuvants, the role is to cause a kind of hypersensitivity and the body to react quickly to this new protein that is being entered. So everything, the body reacts and all kinds of antibodies start getting generated. So it could possibly be that what we are closely associated with vaccination may be because of the adjuvants. It's tough to make a direct association, and just a temporal sequence of the event occurring immediately or within a short time cannot essentially prove association. We need to have scientific basis. We need to have a definite science behind being able to say that it's related to the vaccine. Reported effects have been uveitis, so check for choroidal thickening. It may be subclinical also. Optic neuritis, optic perineuritis, and conjunctivitis. These have been reported with vaccination, more with the Pfizer and the Moderna in the US, and not so many with us. But of course, probably we're still learning. So just 1 or 2 queries which we always have in our mind. So vaccination in the setting of immunosuppression. A lot of our patients are on long-term steroids, immunosuppressive drugs. So can vaccination be given? So patients on short-term immunosuppression, you can plan the vaccination after the treatment is stopped. For patients on long-term immunosuppression, stress to them the importance of prevention, that they should not have the chance or expose themselves to possible COVID. And it's extremely important because they have a heightened risk. Those on long-term immunosuppression, you can advise them to continue with their steroids and the vaccination as per their opportunity. However, antibodies should be tested to look for the adequacy of the response. We have changed our management techniques that we were discussing. We don't do direct ophthalmoscopy anymore, so we do an indirect and do a 90D on the slit lamp with a shield. Routine follow-ups are rescheduled. We do telephonic and telemedicine. Patients can now do visual acuity, color, visual fields using the available apps on the phone or the tab. Precautions in clinical visits. It's important to wear masks, repeat hand sanitization, minimize crosstalk, slit lamp shields. We've modified our teaching by more case vignettes and discussions rather than obvious examination. So just a bit about the management. In any patient of optic neuritis or any neurological or neuro-ophthalmological condition, look for COVID. Do an RT-PCR if he has not been tested before. If there is a history of COVID symptoms, or is absolutely okay, do a serum analysis, so a serology test, so that it may not be COVID-related presenting to us late. Look for ophthalmic issues in COVID patients. A lot of patients have even minor eye problems. They may be associated, may not be associated, but important to examine and work them up. Transient diplopia, color defects, walking difficulties. Some questions we still need answers as we are, getting more patients understanding. Should treatment of patients on immunosuppression steroids be altered who have recently got COVID? Treatment of patients of optic neuritis being given steroids if they develop COVID. It's time as we will understand how closely related COVID is to some of the neuro-ophthalmic conditions that we're seeing. But we are seeing a definitely higher number of these conditions as compared to any other respiratory virus pandemic. So there may definitely be some association. So COVID is a multisystemic disorder. Neuro-ophthalmic signs are being presented. No clear mechanism as such, but immune-mediated possibility. Management of either disease has really not changed. So even if he has neuro-ophthalmic signs or probably any other disease, COVID treatment remains as it is. Or if a patient with neuro-ophthalmic condition on treatment develops COVID, our management still remains the same. Unless contraindicated, we still continue to give steroids. and patient must practice COVID appropriate behavior, and vaccination is advisable in almost all conditions that we know of. So thank you for the opportunity, and we could take questions.
Thank you so much, Dr. Rahit. I think I'm very tempted to actually translate your presentation into various vernacular languages and show it to the people who are refusing to, follow COVID protocol all over the country. And it will be a lesson for them, I think, to understand what they're dealing with. Would you be happy to take a couple of questions, Dr. Rohit?
Sure, absolutely. I mean, to whatever our limited knowledge that we have at the moment.
Thank you so much. Sujata, would you be kind enough to start the process?
Yeah, the excellent talk as usual, Dr. Rohit, and we did learn a lot from your talk. One of the clinical doubts that we are right now having is that if a patient presents with optic neuritis and is COVID positive, should we or should we not start the intravenous methylprednisolone? Because as you know, in the early days, meaning the early on days of COVID, steroids increase the replication of the virus and might actually aggravate the clinical course of the disease. So that is something which we kind of are in a dilemma in the few patients that we have got the optic neuritis with a COVID positive, which we actually diagnosed.
So yes, it's a major dilemma, and I don't think there are any clear answers. So I'll just kind of divide COVID and optic neuritis into three components. One, in fact, the bulk are those patients who come to us with optic neuritis as a routine before giving IV steroids. We do an RT-PCR. The RT-PCR comes positive. Asymptomatic, the patient has no symptom. There is no reason for us to actually have suspected, except the fact that we were thinking of IV steroids. In those conditions, although it would always be advisable to discuss with a physician, but if a patient is asymptomatic and you are unable to access a physician, although that's not something difficult, but ideally you would take an opinion of the physician about contraindications of giving IV steroids. But unless the patient has significant early infiltration in the lungs, or they think that it's an early onset, or right now it's a real replication phase, usually the physicians haven't stopped us from giving IV methylprednisolone. So essentially it is still safe. Now, if you have a patient presenting early with symptoms of COVID and optic neuritis, there is a major dilemma whether to give steroids or not. We've had fortunately, we have only one such case where we were worried. And we did give, after a day or two with discussions with the physician, we did give IV methylprednisolone, but under cover of an antiviral. So that was the one condition. But like I said, the bulk of the patients we see who are absolutely asymptomatic. And the third category is who present to us late, about a month or so after their COVID. So there is no real dilemma. The real dilemma only comes if the patient is symptomatic for COVID and develops optic nerve. So there anyway, we kind of pause and try and get a complete examination, could get an MRI brain and orbits, get a physician test, because it may actually be part of the COVID disease itself and, may not just be optic neuritis, primary demyelinating. So starting of IV methylprednisolone may not be that pressing at the moment, because if it's only demyelinating that we are aggressively intervening, otherwise we would rather want to know what is the cause of the, it could be, like I said, part of the COVID problem as we are picking up. So that's what our limited knowledge or experience is telling us how we are practicing at the moment. But
Dr. Chakraborty, please. Dr. Tutul Chakraborty, are you there? Okay, probably we can revisit. Oh, Dr. Chakraborty, you're there. Please unmute. Dr. Chakraborty, please unmute yourself.
Can you hear me?
Yes, better.
Yeah. Dr. Rohit, thank you for your excellent lecture. Just one query. That disc edema or papilloedema, what you have mentioned, is directly COVID related, or it is due to that lockdown, lethargy, overeating, increased obesity, or something patients are taking some other medicine due to that? And if so, what would be the treatment guideline in that case?
So, like I said, that sometimes it's a little difficult to actually get a direct association. But yeah, many patients are having, I mean, many people, I think all of us are having a bit of weight gain now that we are not moving around. So, weight gain is an association, and that is something that may possibly be causing the increased number of patients of papilloedema. But like I said, that's something which you can only advise them. But the key thing is that even if there is a patient who appears to be because of weight gain or, you know, fits in the profile of an IIH, overweight, recent weight gain, you know, youngish lady, even then we are now more aggressively looking at an MRI plus MRV, because we don't want to miss the cerebral venous thrombosis that is, you know, much more likely to occur in patients of COVID. So, you know, earlier when we would actually apply our mind to see likelihood, possibility, just get an MRI and try and see for flow voids and all on the MRI without actually asking the patient to pay for an MRV. Now we are, you know, being more aggressive because we don't want to miss that. You can't afford to not treat an venous sinus thrombosis and treat it like an IIH. So, we are learning our ways, but probably both the reasons are there. A lot of patients are there because of weight gain, because of a sedentary lifestyle, and its associations. But the risk is definitely there of cortical venous thrombosis or cerebral venous thrombosis. So you can't rule that out, and I think that should be really looked at. That is the first thing we are doing, again, like a knee-jerk reflex, get an MRI plus MRV the moment a patient comes with papilloedema.
And one thing I would like to in your situation or in your clinic, how often you do, I mean, before COVID or even now, how often you do B scan for to understand a patient with benign intracranial hypertension, to either to exclude drusen, optic nerve drusen, and also to know, I mean, increased intracranial pressure, both the cases.
So, I mean, I would say I don't do B scans much. Only when I suspect that there may be drusens that I do an A and B scan to actually see for that. Somehow in our hands, we have not found the sensitivity that has been reported of B scan for picking up IIH. So usually if they are well established IIH or disc edemas or papilloedemas, you can clinically fairly well estimate them. So you don't actually need them. But if they are very early, somehow we have not had the skills to be able to, you know, differentiate from pseudo papilloedema and true papilloedema in very early IIH. In those cases, I would often follow up the patient and see how the discs are changing over a week or so. And if I suspect a drusen, yes, then I would actually. So if I suspect that it's a pseudo papilloedema, I'll follow up the patient maybe for a week or 2 weeks or see for change in disc. If I don't see a change in disc and I suspect that it possibly is the same and there is a kind of risk that there is a drusen, I'll go ahead for a B scan. But otherwise, as of now, we test our clinical skills a lot more. And B scans, that's why somehow we didn't find it, you know, fitting in very well in our, you know, kind of decision making at the moment.
Some groups do the B scan to find out if they are good candidates for optic nerve sheath penetrations. Yeah, especially the Nara and Netralia group.
Yeah, I know. Exactly, they do it for that, but somehow, you know, we've been more comfortable still sticking with an MRI orbits if we are, you know, thinking on them, because there are two reasons basically. One, of course, lack of our possible clinical skills, so we're still not as good to be able to differentiate how much fluid is there, because safety is the key feature when you're entering. And the other thing is that, you know, sometimes a thinner optic nerve, because of a long-term atrophy, may still have a lot of fluid around the optic nerve with the sheath showing a lot of fluid. But that does not give you a good prognosis long-term, although you still are safe enough to go in, but you don't predict or you're not able to say. So if you see thinner nerves with not so much fluid, you are able to actually prognosticate the patient and advise them that there is a possibility that they may not gain too much vision after the procedure. That's it.
Thank you so much, Dr. Rohit. You have been so lucid that even us lesser mortals have been able to understand what you're talking about. And thanks again for giving us your time on a very, busy schedule. Take care, and we should hopefully meet you sometime soon in person.
Thank you. I really hope so. We were looking forward to the Calcutta conference, but anyway, we'll meet virtually. But again, sometime in the future, in better times.
Yes, better late than never.
Thank you.
Thank you so much. Now we have the interesting bits. Of course, what we have heard now, seen now, that those things will stay with us. But we have the youngsters now. So Prachi Subedar Ghosh, Ruby Mishra, and Arindam Roy will present cases to whet our appetite regarding neuro-ophthalmology. So Prachi, would you be kind enough to tee off?
Can you hear me? Hello, can you see my slides?
Yes.
Yes, Prachi, quite nice and clear.
Yeah. First of all, I would like to thank you, the President and the Secretary, to give me the opportunity to speak. And I'm actually nervous speaking in front of so big stalwarts in our profession. But I'm very much excited to speak in front of my mentor, Dr. Sujata Guha. So my topic is ethambutol toxicity. I'll just go ahead. So we had a female, 34-year female, who was writer by profession. She came with complaints of diminution of vision in the left eye since 2 weeks. She also had history of fever on and off since 5 months, along with weight loss. She also had severe backache, and there was no history of trauma, numbness, paresthesia, or any signs of raised intracranial tension. She was diagnosed as extrapulmonary TB, and she was put on category 1 antituberculous medications, HRZES, since last 3 months. Personal, social, family history were insignificant. General examination, patient was conscious, cooperative, and she was well oriented to time, place, and person. Systemic examination was normal. Moving on to her ocular examination, her best corrected visual acuity in the right eye was 6.6, left eye it was 6.9, near vision was normal, intraocular pressure with Goldman's applanation was normal, color vision done with Ishihara isochromatic plates. Right eye she had good response, but in the left eye it was a slow and strained response. Extraocular muscles, the movement was full, free, and painless. On slit-term examination, anti-segment was normal. The pupillary response in both eyes were brisk, and there was no RAPD. Moving on to fundus examination, in the left eye she had mild tempora pallor. Other than that, foveal reflex were bright, background retina was normal, the vitreoretinal media was also very clear. So we went ahead with 24-2 fields. And on the fields, we saw centrocecal scotoma in the left eye. So we advised the patient we referred patient back to the pulmonologist and asked to cessate the ethambutol and put the patient on any alternating medication. So she was put on ethionamide instead of ethambutol. She was also advised to take vitamin B12 and pyridoxine vitamin B6 supplements. And she was asked to keep under regular follow-ups. After 5 weeks, we noticed the centrocecal scotoma started to vanish. So this was after 5 weeks of the stopping of ethambutol. So my take-home message from this is all the patients under antituberculous medication should be referred to an ophthalmologist early for examination. Basic screening of visual functions of the patient, which include patient's visual acuity, color vision, visual fields, along with macular OCT. Actually, I was not able to do the macular OCT in this patient. I would also like to say that creating awareness amongst physicians, DOTS providers specifically, about visual impairment due to ethambutol use and early reporting of these patients and referral to appropriate healthcare providers is the need of the hour. Thank you so much.
Thank you so much, Prachi. Ruby, will you be kindly ready with your presentation?
Yes, sir.
So shall I share my screen? Am I audible, sir? Am I audible, sir?
Yes, Ruby, you are audible.
A very good evening, all of you. Thank you, KO, for this excellent opportunity. Thank you, Chandrima ma'am, Rajesh sir, Chandana ma'am, Surajit sir, Sujata ma'am, and thank you, Dr. Rohit sir, for being such a wonderful teacher during my JRship and SRship years. So it was, I was blessed to be under your unit and get all those advices and information. So let me start the case. It's a case. A 56-year-old male had come to our OPD around 1.5 years ago with sudden dimness of vision in the right eye. Was also diminished in the right eye. Left eye had a normal color vision. And on fundoscopy, I found diffuse pallor of the optic disc along with edema, while the left eye had a normal fundus, a normal 0.3:1 cupping, and the macula was held in both the eyes. Now, since I asked the patient carefully, and the patient said that he had a history of fever and the weakness for the past 2 weeks, and also bilateral temporal headache for the past 1 month. Or myalgia, and on palpation, I could not find any tenderness of the temporal artery or any diminished pulsation in the temporal artery. Blood pressure was normal, and bilateral upper extremities showed symmetrical pulses and blood pressure. However, the perimetry showed depressed visual fields in the right eye. Central vision was spared, and the left eye had normal vision. And the patient had shown a local doctor close to his house, and he had advised an MRI, which was normal. So I ordered a set of investigations: complete hemogram, blood sugar, lipid profile, C-reactive protein, and I asked him to follow up as early as possible with these reports. And since there was diffuse edema along with pallor, I started him an oral steroid around 60 milligrams, and I asked him to follow up in 1 or 2 days. However, the patient did not come back the next week. He came after 10 days with bilateral vision loss. The vision in the left eye had fallen down to finger counting close to face, and the right eye vision was 1/60. Pupils were sluggish in both the eyes, and the left eye was also showing some mild edema. The right eye had some pallor with edema, as was seen earlier. Unfortunately, I don't have these pictures because patient was hysterical at that time. Retina macula was normal. So when I asked the patient, he said that he had not started taking the medications because he was waiting for the reports, and he would take the medicines only after the reports were out. So the blood sugar, lipid profile, everything was normal. Hemogram showed mild anemia, but what was characteristic was raised ESR and CRP. ESR was 70 millimeters per hour and CRP was 22, which was very high. So on a suspicion of giant cell arteritis, and since the patient had severe visual loss in both the eyes, I immediately sent the patient to emergency department, and the patient was started on IV methylprednisolone 1 gram per day for 3 consecutive days. Of course, a baseline chest X-ray was done, and blood sugar was also normal. And on the 3rd day, the patient had slight improvement of vision. Vision in the right eye was 4/60, and in the left eye it had increased to 5/60.
Dr. Ruby, did you share your screen? Because we can't see anything.
Oh, sorry. Isn't it visible, ma'am?
No. No. It's not visible.
There's a share screen at the bottom of your thing. Yes, now it is shared. Yes, fine. Please go to slideshow. Yeah, that's perfect. Yeah.
Shall I start again, ma'am?
I think so. If you run through it a little fast.
I'll run through it. The 56-year-old man I talked about had presented with sudden onset of visual loss 4 days back, which was painless, and the patient was having no systemic illnesses. And the vision was 2/60 in the right eye, and the left was normal, with diffuse edema and pallor in the right eye. And the patient did not have reports, so I asked him to follow up with reports. And meanwhile, I started him on oral steroids, as I've said. But the patient did not start medications despite the pallor and the edema. And then he came back after 10 days with diffuse bilateral visual loss. So now the other eye also had developed edema, and the vision had come down to finger counting. So the patient was immediately sent to the emergency department, and I started him on IV prednisolone 1 gram per day for 3 consecutive days. And this was because the patient had a very high ESR and CRP, as I've already mentioned. The ESR was 70 and CRP was 22. And after giving IV steroids for 3 days, the vision had improved. In the right eye, it was 4/60, and in the left eye, it was 5/60. ESR had come down slightly, but it was still high, 50, and CRP was 18. And after that, because 3 days have already elapsed and the patient has started signs of improvement, I started him on oral prednisolone, 1 milligrams per kg body weight. That was around 80 milligrams. And of course, I added some proton pump inhibitors to prevent gastric irritation, and also referred him to a rheumatologist. The rheumatologist saw the patient, and the temporal artery biopsy was done, which came positive. And he asked to continue the steroids, and also started him on low dose of aspirin, calcium supplements, and gave him a host of investigations, echocardiography, chest X-ray, MR angiography, to look for any other extracranial manifestations of vasculitis. And the patient was regularly followed up in the OPD on a weekly basis with regular monitoring of ESR and CRP. By 1 week, the vision has slightly improved further. In the right eye, it was 5/60, and in the left eye, it was 6/60. ESR was still high. It was come down to 38, and CRP was 15. So the patient now was explained about the side effects of long-term steroids, and the need for a long-term follow-up and prolonged therapy, maybe for years or so, and chances of ischemic complications due to the vasculitis, the disease process itself, like chances of stroke, dissecting aneurysm of the aorta, or myocardial infarction. And the patient was regularly followed up. Initially, the follow-up was bi-weekly and then once a month, and the steroid dose was gradually tapered, initially at the rate of 10 milligrams at every 2 weeks intervals, and after a few months, when the patient came after 6 weeks, the vision was still stable, the patient's symptoms had improved, there was no headache, there were no constitutional symptoms. So I now gradually tapered down the steroid at the rate of 5 milligrams per day at every 2 weeks intervals. So now the patient was steady, and he was better. And at 5 months, the patient was still maintaining that vision of 6/60 in the right eye and 6/24 in the left eye, with an ESR of 24 and CRP of 7.6. He was now on 15 milligrams per day. So then again, I followed the patient after 1 month, and with a tapering dose of steroid. And at 6 months, this is how the disc looked like, color in both the eyes, right more than left. And visual fields were still depressed, and the vision was 6/60 in the right eye and 6/24 in the left eye. And ESR was still slightly on the higher side, but the patient was symptomatically okay with depressed visual fields, however. And now he was on 10 milligrams of oral prednisolone. He was advised to follow up with the rheumatologist and continue the steroid. And I asked him to come again after 2 months. I was thinking of further tapering the steroid regimen. However, after that, the lockdown came, and due to the COVID lockdown, the patient was lost to follow up. I traced the patient. I had repeatedly advised him never to stop steroids unless the physician advises him to. And I just hope that the patient does come back to me after a few more months, or maybe when he is able to come back, because he comes from Bihar. And I lay this case here for a discussion, like whether I should have started IV steroids, because there have been some studies which show that oral steroids are as good as IV steroids, and there's no need for IV steroids, and how long to continue it for years or so, what are the chances of relapse or recurrence, and whether to add on immunosuppressive therapy like tocilizumab or methotrexate, and what is the role of aspirin, whether there are any chances of ischemic complications despite the continuation of aspirin, and the role of the biomarkers for monitoring the disease process, because even with normal ESR and CRP levels, patients have been found to have a high recurrence rate, around 50% or so in some studies. So these are a few tricky areas, and I just present my case here so that further discussions may be made.
Okay, Ruby, thank you. Arindam, please. And don't forget to share.
By the time Arindam is ready, can we have some discussion, Rajesh, Dr. Rajesh?
Chandranandi, it might be a good idea to have it all at the end, because that way...
But Arindam, I don't know how much time he will take.
Arindam, are you ready?
Yes, sir, I'm ready.
Okay, then please start sharing.
Okay.
Is it visible?
Yes, it is.
Make it a full screen, Arindam. Make it a full screen. Yes. Yes.
Very nice. Go on.
Yeah. Good evening, friends and seniors. I would take this opportunity to thank Kolkata Academy of Ophthalmology for this opportunity, and also I would like to congratulate all of my previous speakers. They have done very nice discussions. I will be presenting a case of idiopathic intracranial hypertension in a pediatric age group patient, which is uncommon. Idiopathic intracranial hypertension in a pediatric age group is rather uncommon. The usual presentation of IIH is in an obese female, generally obese female, age group being 20 to 50 years, who turn up to your OPD or chamber with complaints of headache, pulsatile tinnitus, and on examination of the fundus you find disc edema, which is revealed to be papilloedema. If you go for a neurological examination like MRI scan or a CT scan, you will not find any abnormal neurological finding, except you may find occasional sixth cranial palsy, sometimes rarely even fourth cranial palsy also, or even seventh also. But out of the six cranial nerves, out of the three cranial nerves, the sixth cranial palsy is most common. We'll also be seeing an elevated intracranial pressure, a normal CSF composition, and neuroimaging I just explained, and there's something called revised Dandy criteria given in 1985, which sums up this 5 or 6 diagnostic criteria. This is for textbooks. Now our case is that of a 3-year-old boy who is a known case of hemophilia A. That patient, he came to the OPD complaining of headache, nausea, occasional episodes of vomiting for the last 10 days, and complaining of horizontal diplopia. On examination, we found an inward deviation of both eyes, right more prominent than the left, for the last 10 days or so, around 2 weeks. The child was alert and mildly irritable, but there was no history of fever or convulsions. And for baseline investigations, we did this CBC and whole battery of tests of the blood. We only found an increased thyroid stimulating hormone with a normal free T3 and T4, suggesting hypothyroidism, clinical hypothyroidism. So the unaided visual acuity of this child was 6/60 and 6/36, but with hypermetropic correction amounting to around plus 3 to 3.5 diopters. The patient had 6/9 vision, both eyes. The pupillary reaction by good illumination was normal. Because of the deviation, we did Hirschbach test with the torchlight, and we found out the deviation to be in the right eye around 30 degrees and for the left eye around 15 degrees. As you can see in the clinical photo, the right eye is a bit more iso-deviated than the left eye, but on ocular movement performance, we found a restricted abduction of both eyes, right more than the left. I will be showing you the clinical photograph very shortly about the ocular movements. And there was, and this is all suggestive of bilateral six-nerve paresis, if not palsy. And we did a contrast-enhanced MRI scan, which revealed no abnormality. See, the ocular enamel presentation, this photograph, I would like to say, okay, this is not exactly representative photographs, but this is the best I could search out from my album. So on the central gaze, right eye and left eye both are iso-deviated, right more than the left. When the patient was asked to look to the right side, you could see there's a restriction of abduction. There's a restriction of abduction of the right eye, not so much for the left eye. But on left gaze, it seems more or less in a better situation. Now on fundus photograph, which we documented, this is in 2015, there is disc edema, bilateral disc edema. Apart from that, the fundus is grossly normal. So this is our provisional diagnosis: idiopathic intracranial hypertension with bilateral 6-nerve paresis in a hypothyroid and hemophilic child, 3-year-old boy. Now, the treatment we give after we consulted neurology and pediatric departments, and the treatment we started the child on is oral acetazolamide and domperidone, along with tablet.
Hello. Hello.
Are you there, Arindam? Have we lost him?
I think there are some network issues.
Okay. Okay.
Can the host do something about this?
Hello, Rajesh.
Yes.
Hello. Am I audible?
Let me call Arindam and see whether he can pick up. Has he stopped?
Yeah, he's disconnected, I think.
He's disconnected, actually.
Shall
we go on with the discussions then?
Yes, yes.
And then come back to Arindam later on?
Right, right.
Is that okay? Dr. Chakraborty, would you like to start the discussion about these 3 cases? Well, 2.5 cases rather.
Hello.
I think Arindam is back. Yeah.
Arindam?
Yeah, sorry for that glitch. There was, I think, some interruption of the internet signal.
So how many slides for you to go?
I think 3 or 4.
Okay. Just whiz through them, please. We are running a little bit late.
Yeah, I understand.
As quickly as you can, huh?
Yeah. So I was in this slide.
No, Arindam, you just back up first.
Okay. So we gave prednisolone and there was a symptomatic improvement, and in the further 2 weeks following up, we found there was further improvement with correction of eye deviation. And this is after 2 weeks ocular alignment. You can see central part in the normal gaze, it is absolutely centered, and there is not much restriction of abduction. So the course of the disease, there was marked improvement from the 2nd week onwards. By the 6th week, the optic disc margins were near normal, and by the and there was just a minimal deficit of the right eye. Now, management of similar cases, we will prefer acetazolamide is the drug of choice at the rate of 50 mg per kg per day, and treatment may be continued up to 3 to 9 months. We can also give furosemide or topiramate for synergistic benefit. So discussion, the pediatrics are more likely to be asymptomatic or present with atypical symptoms. The incidence is more among adolescents than among prepubertal children. And there is no apparent association with gender or obesity in children in the pediatric age group.
Arindam, let's leave the discussion for the panelists, shall we? And then you can add on.
Okay, sure.
Thank you.
Okay.
Dr. Chakraborty, would you kindly start?
Yeah, Arindam, can you please tell us how, what are the points of diagnosis? How you are very sure about it is a case of benign intracranial hypertension, because patient has so many things. Yes, hypothyroid could lead to that, but how the intracranial pressure is high, how you come to that diagnosis? Could you please just tell us?
Yeah, sure. Madam, the patient came to us in the OPD with complaining of headache.
Sorry. Stop sharing.
Please stop sharing.
Okay.
Yeah, thank you. Yeah, carry on.
Yeah. Ma'am, what I am saying is that the child came to us in the OPD complaining of headache. The patient basically did not come to us, it came to the pediatrics department. And the pediatrics department, they performed a crude ophthalmoscope and found that something was wrong in the fundus. So they sent over to us, and we found out there was disc edema. Now, disc edema in a child is very unusual, especially because there was no RAPD, there was no pupillary reactions, where everything normal. The vision was also 6/9 with +3 hypermetric correction. So when everything was there, we had a suspicion it might be because of this papilloedema, might be because of raised intracranial tension, which could be because of intraocular tumors and or maybe some other more sinister pathologies. So we sent over the child for MRI scan. The contrast enhanced MRI scan came to be normal. So I mean that kills the diagnosis, because idiopathic intracranial hypertension means there is no identifiable cause. And there was no identifiable cause for the macular edema, for the disc edema. The scans were normal, and that your symptoms were also, and the signs were also, but confirmatory, leading us to idiopathic intracranial hypertension.
But is it grade 2 papilloedema? I mean, if you just share your this photograph with us, I mean, just could you please share that this photograph? Is it
sure.
Yeah, and this asymmetric papilloedema, disc edema. You share with us, and your patient is hypermetropic, so there may be some kind of dismerging blooding. It could be
yes, there could be pseudo disc edema. You're right.
How you can just it's a little bit difficult to understand that. Yeah. Your left eye, I mean,
Madam, if you note carefully, the disc edema is just sparing the temporal part of the disc. Just a small chunk around 30 degrees, not much of a margin blurring is there. But apart from that, the edema is there.
Other eye is not, is this grade 2 perhaps? Is the right eye is grade 2, right? Left eye, is it grade 2? I'm not sure. I'm not sure. I mean, you just because yes, and it could be Zusan also, and it could be pseudo also. That's why.
With probably difficult to make up in the photo, isn't it?
Hello.
Actually, it's very difficult to. Yeah,
difficult to make up.
Maybe can I just interfere to do this? Yeah. Actually, this case was first seen by me, and initially we could not take any photograph because the child was too much of irritable. So it was a frank papilloedema, disc edema at that time. But we took this photograph after 1 week when the child is already actually recovering that time. So maybe that time the disc edema has started regressing. So that is not, otherwise you can see the tortuous vessels that also goes in favor of this papilloedema. The vessels are tortuous.
In the background of a bilateral sixth nerve paresis, and it is very unlikely that the disc is going to have a pseudo disc edema, because the child has presented with a sudden onset esotropia. +3 diopters is not really cannot account for the abduction deficit, even if you can say that it might be accommodative esotropia, but there is a clear abduction deficit that was seen in the slides. And so it is unlikely to be a pseudo disc edema in the background of a bilateral sixth nerve paresis. And if we have a combination of a sixth nerve paresis with a papilloedema, MRI contrast with a MRV would actually have given us a lot of clues. If you see, sometimes this is a 3-year-old child. Sometimes these children can have congenital absence or congenital stenosis of the cortical venous sinuses. Second, they sometimes can present with cortical venous sinus thrombosis, because this child has got a history of hemophilia, which can lead to anemia. So this is a hypercoagulable state it can lead to. So MRI with MRV could have led to a more definitive diagnosis of the cause of the raised intracranial pressure in this child.
Thank you.
So this is my, how we confirm that the patient is having intracranial hypertension. Usually, that is because what Dr. Sudhata has just mentioned, that these things are lacking, right? We didn't exclude, right? That whether the transverse sinus thrombosis is there or not. Usually, we do an opening pressure in adults, but this is a 3-year-old child. This is a 3-year-old child, so I presume they would have had to put the child under general anesthesia to do an opening pressure.
Madam, I'll just interrupt. The patient was hemophilic also. There was a chance of bleeding.
Yes. Yeah, so that's so many. It's a very good case and very interesting. So that's why so many questions are there, right? Because you cannot do that child. To tap the see whether the opening pressure was there. So there is so many. It's not a very clear-cut case.
Actually. Right. In view of paucity of time, shall we move on to Ruby's case? Ruby Mishra. Dr. Chakraborty, you can start again with the discussion, please.
Ruby's case was this only thing that, do you think the patient is a little bit younger than the typical age? It's a 56 years old, that lady. Am I right, Dr. Ruby?
Yes. Yes, ma'am. Actually, the age range is above 50, 56 to 94. So usually we get it around 60 or more than that. But in fact, initially I was thinking whether it's a giant cell arteritis or not, just because of the age. And that is why I was thinking whether to start steroids or not. But later when the ESR and CRP readings did come, I hope I'm audible, ma'am.
Yes, you are.
Absolutely.
But later when the ESR and the CRP reports did come, so at that time I didn't have any doubts, though it is a bit unlikely. But above 50, it has been reported. There have been cases where people above 50, 51, 52 also have shown cases of giant cell arteritis.
Thank you, Ruby. Shall I go on to Dr. Guha? Sujata, would you kindly say something about this case?
See, at age 56, when a patient presents with a unilateral disc edema, as this patient presented, there could be two differentials. One is a neuritis, and one is a ischemic event, that is a ischemic optic neuropathy. So the only way to differentiate between the two, yes, of course, there will be risk factors like vasculopathic risk factors like diabetes, hypertension, which can give us a clue that it could be an ischemic event. But in the absence of such vasculopathic risk factors, MRI with a contrast is the differentiating factor to differentiate between the two. Whether the optic nerve is enhanced on contrast gives a clue that we are dealing with optic neuritis or not. Some of the atypical optic neuritis, like MOG-associated NMO, can present with a bilateral sequential disc edema. And the age 56 for an ischemic event is an outlier. It is not really a very typical age where we have a arteritic ischemic optic neuropathy. Usually, if we see more of non-arteritic ischemic optic neuropathy. So this is an interesting case because it is an outlier. So one thing I wanted to stress about this case is, number one, to have a MRI with a contrast to look for enhancement of the optic nerve. If there is enhancement, the patient should be started on an intravenous methylprednisolone first, followed by oral steroids. We usually don't start with oral steroids. It has been seen in the ONTT trials that oral steroids can actually cause harm than benefit. And if it is an ischemic event, we usually look for the parameters, a routine blood test with a ESR, which will actually be pointing towards arteritic optic neuropathy. And if the ESR is high, yes, we should be ready for the second eye, which is very, very common in giant cell arteritic optic neuritis, because and it is considered to be a medical emergency. And these patients are put on initially intravenous methylprednisolone, then switch to oral steroids, and the oral steroids are continued for a very long time, probably for years. And in between, we usually monitor with, in the absence of better monitoring agent with the ESR and the CRP. So if the CRP is raised in between along with the ESR, we increase the dose of the oral steroids. And so, we actually would like to switch them over to immunosuppressives, because long-term oral steroids in elderly can have a lot of issues. We do it in conjunction with the physician.
Thank you so much, Sujata. Now, Prachi.
Stop sharing your screen. Stop sharing your screen.
Yes. Ruby, stop sharing your screen.
Prachi, you needn't share your screen unless you're asked to.
You don't have to.
Discussion. Please don't share your screen, yeah.
Dr. Chakraborty?
Yeah. Prachi, I can't see Prachi.
Yes, ma'am. I'm here. Yes, ma'am.
You put your screen on gallery view.
Prachi, I mean, why would you like to do macular OCT for these patients, number one? Number two, is it for follow-up or is it for the diagnosis, number one? And because you have your visual field, I mean, you have done the color vision, so what else would you like to see, I mean, through macular OCT for this case, number one? Whether just to check the prognosis, or to follow up the patient, or for the basic diagnosis. This is number one. And number two, what was the initial dose of ethambutol?
Thank you, ma'am, for the question. Ma'am, we have to follow a particular protocol while investigating in these cases like toxic optic neuropathies. First is your vision, then color vision, followed by visual fields. And these days we do macular OCT. Basically, there is an axial neuritis which happens, or periaxial neuritis which can happen due to toxic optic neuropathies. So papillomacular bundle is usually affected, and ganglion cell layer and RFNL complex gets affected or basically thinned out after some time because of overdosage. So for prognostic value, macular OCT is very good. So you can keep a follow-up and track of record over the period of time, that how much the macula is thinning, and after stopping of the ethambutol, how much improvement the patient has showed. There you can do VP also. There is P100 latency reduces. There are reports that people do MFERG. There is N1P1 latency reduces in that. And coming to your second question, she was put on to ethambutol is 275 milligram in QID dosage.
How much? I just
275 milligram, ma'am. Hello.
275 milligram. That is total.
No, ma'am. No, ma'am. 275 milligram QID dosage she has been taking on for last 3 months.
That means
2 months. 2 months was the intensive phase.
Per day, what was the dose?
1100.
Less than 15 milligram, right?
No, that is the cumulative dose is more. It is 16.92 something. The cumulative dose increased when we calculate the cumulative dose. It is more than 15. So safe dose is 15 milligram per kg body weight, but it was more in this particular female. So we had asked to stop ethambutol and put her on an alternative therapy. So they had put her on ethionamide, which is quite effective.
Is fine. That is fine. I mean, just I wanted to know that how much was the per day dose. I mean, because if it is less than 15 milligram or within 15 to 25 milligram, then I mean the chances are more than when it is more than 35 milligram per body weight. So that I just want to ensure.
No, ma'am. Actually, there is a thing in revised national this RNTCP program. 2017, there was a updated PDF which we had got. In that, what they have given is, even if the patient is drug sensitive, even patient could not be seropositive but be showing signs and symptoms, they have to be put on particular initiation dose. It should be 1100 milligram per kg body weight, and the cumulative dose obviously goes beyond 15. So they are more into that toxic category. So they may fall into that. They may get ethambutol toxicity in the future. So these kind of patients you have to keep under regular follow-ups and keep on checking their vision and color vision color vision and visual fields.
Thank you.
That I'm saying. I mean, it could happen even in the lower dose also, but chances are less.
Yes.
Thank you.
Ethambutol
Sujata,
toxicity.
please.
Yeah, ethambutol toxicity has now increased quite a bit because of the revised criteria of management of these tuberculosis patients. And in fact, you will be glad to know that we had a meeting with the DOT centers, the in charges, and they have agreed to put up these visual acuity Snellen's chart in the DOT centers to actually screen for them. But that aside, to answer the question of why macular OCT, macular GC, the ganglion cell layer thickness and the IPL thickness can actually prognosticate. If there is an early thinning of the ganglion cell layer, then the prognosis of vision after stopping the ethambutol reduces. So we use it mainly for prognosticating the disease.
This is for this is for predicting how much vision exactly, because this is a paper on IOVS.
Yes.
About the macular OCT. So that's what I'm saying. This is just giving the prediction how much vision you will recover, not for the diagnostic purpose.
No.
Yeah. That is.
Okay. Thank you so much, ladies and gentlemen. It was really, really illuminating for all of us in all sense of the term. May I hand you over now to our very capable secretary, Dr. Surajit Chakraborty. Thank you, Surajit.
Thank you, Rajastha. It was indeed a very illuminating talk from all the speakers and nicely presented by all the presenters. So may I call Dr. Chandana Chakraborty, who was the key person for contacting all the speakers and arranging the program, to give the vote of thanks for today's evening.
Thank you all. Before going for vote of thanks, I have two pertinent questions to Prachi. Prachi, you said pupil reaction was normal. So is it possible in the case of retrobulbar neuritis or optic neuritis, what you are saying, the pupil is normal? That is my query. Another is vision at follow-up, whether the vision improved and at what week, when the vision started improving, because that is more important. We want to know from you whether the vision improved.
Ma'am, I'll take your first question first. Ma'am, there are case reports that because of ethambutol, there were reports of retrobulbar neuritis and optic neuritis. In those cases, when the optic nerve is involved, there is neuritis, you will get a pupillary response like RAPD. You will get that. And in those cases, there was optic chiasmal involvement, MRI was done. They were very rare findings, but it has been seen. Commonly, peripheral neuritis is seen because of isoniazid. But with ethambutol also it has been documented. Now coming on to your second question, you said visual acuity. Her visual acuity, ma'am, improved after almost 2 months period. She started showing vanishing of that particular scotoma. Color vision also started to improve, but the visual acuity became 6x after span of 2 months.
Okay. Thank you. Thanks to all. My sincere thanks to all the viewers first. A big thanks to our two eminent guest speakers, Dr. Pramod Pal and Dr. Rohit Saxena. Thanks to the other speakers, the young brigades, Dr. Prachi, Dr. Ruby and Dr. Arindam. They have done really a very excellent job. Thanks to our panelists, Dr. Tutul Chakraborty and Dr. Sujata Guho. They were really very excellent to explain all the doubts. We are thankful to them. A big thank to Dr. Rajesh Majumdar Chaudhary, who has done his job very nicely. And my heartiest thanks to our President, Dr. Chandrima Pal, and Dr. Secretary, Dr. Surajit, who are very instrumental in arranging this webinar. Thanks to all. Thanks to the viewers again. See you all next in some of our meetings. This was really excellent to have such eminent speakers and all. Thank you.
Thank you.
I'd just like to say one word that I think Dr. Chandana Chakraborty deserves a huge thank you, because she is the person who organized this entire thing. And I think it was a wonderful evening. It's not my subject, but it was so interesting that I sat through the entire thing and listened to it. And I'm really enlightened with the things I heard. The talks were fantastic. The case presentations were superb. And the panel discussion was much, much above normal. It was fabulous, absolutely. Thank you. Thank you very much. Thank you.